Hi, my name is Anuk, and today I will be pitching Flow.io, an innovation on IO needles that will improve pediatric critical care. An IO needle is a way of getting vascular access by drilling into the bone and is used when IV access is delayed or not possible. An IO needle is often used in pediatric emergency situations because children's veins are small and IO needles are the fastest method of access. Notably, 24% of critical pediatric procedures involve IO access. An IO needle is drilled 1 to 2 finger breadths below the tibial tuberosity at an anterior and medial angle as shown in the figures. There are two commonly used IO needle sizes, the 15 and the 25mm needle. The 15mm needle is typically used with younger patients and infants, and the 25mm needle is typically used in older children. IO needles rely completely on clinical judgment to identify the correct needle size, and in an emergency situation, this determination can be very difficult due to patient variability in soft tissue and bone thickness. This can lead to severe complications like extravasation and infiltration and needle displacement. Extravasation occurs when there's leakage of harmful fluid or drug into surrounding tissue, which causes necrosis and can be fatal. It occurs in nearly 12% of cases. And then, due to the smooth design of IO needles, they can frequently come out during transport between hospital rooms, which severely delays care. These problems ultimately brought us to our needs statement. Pediatric ER and ICU providers need a safer way to insert intraosseous needles because of current risks associated with fluid leakage, tissue damage, and needle displacement. After finding our needs statement, we had some ideas and early innovations on how to solve the problems commonly associated with IO needles. However, we quickly realized that the current research related to measurements for IO needles was based on anterior-posterior x-rays. IO needles are placed in the anterior-medial plane, so AP x-rays are not suitable for measurement. Therefore, we collaborated with the University of Minnesota Radiology Department to conduct our own imaging study using a large dataset of 912 scans using MRI and CT imaging, which are 3D imaging modalities. We hand measured 680 pediatric scans from the age range of 0 to 16 in packs with measurements of the medullary canal diameter, the cortical bone thickness, and the soft tissue thickness in each patient, which are all important parameters for IO needle design. To analyze the depth that a 15mm and 25mm needle would penetrate into the bone for any given patient, we created a simulation of this intraosseous needle insertion for all of these patients using both needles to see where an IO needle would end up in this large sample. The 15mm needle was too shallow in 31.6% of cases, while a 25mm needle is too deep in 34.9% of cases. Average soft tissue thickness values do not linearly correlate with age, and the most concerning finding from this study is that the 25mm needle goes too deep even in patients where this needle would typically be used. The findings from the study demonstrate that the current needles are unsafe and allowed us to determine measurements for our own safer needle that can work for all patients. For the first problem of extravasation, our solution is designed with a mechanical shoulder that physically stops the needle and only allows a finite length of the needle to enter into the medullary canal. To identify a safe length for the needle to enter into the intraosseous space, we used our results from our study and found the range of safe lengths for all pediatric patients using an inequality analyzing the needle lengths. Essentially, we made sure that our needle would penetrate into the IO space of the largest patients, while not going too deep even in the smallest patients. To address the second problem of needle displacement, we added self-tapping threads to the front portion of the needle. Once the threaded section is fully inside the bone, the shoulder will rest on the cortical bone layer to prevent any further drilling. To go further into our solution, we have a two-port design consisting of a hub and stylet similar to the current products on the market to make it super easy to use without any additional specialized training. I'll walk through how you can use this needle. The whole needle assembly is drilled into the patient's tibia via a hex bit and drill. Once the needle is in the IO space, the mechanical shoulder will stop you from drilling further, and you can remove the stylet component. This will leave the needle hub connected to the patient. Infusion tubes are connected by a luer lock to the needle hub, allowing for fluids to be dispensed to the patient. Because of our design, utilizing the shoulder to prevent extravasation, the amount of soft tissue a patient has does not make the needle unsafe or require additional sizes, unlike current needles on the market today. We created a prototype and tested it on a training bone used by practitioners using IO needles, and were able to find great success. Our needle stopped at the shoulder regardless amount of the force we put through, and the thread stopped the needle from coming out regardless of the force trying to take it out. Essentially, our prototype was successful, and we're currently using MinCore funding to professionally manufacture our needle. Thank you very much for listening to this presentation,